introduction, I just got some 5 slides we're going to review real quick, and then we'll jump into lecture 2. I was talking with your leadership, student leadership. We're going to take out some classes. I think we're going to mix about 2 or 3 classes, okay? Because we don't need to do all that. I'm going to just get to the point. I'm going to give y'all what you need to do well in my class, right? Okay. Yeah, silly. Okay. So let's just do really quick. We'll go over about 5 slides because y'all are going to see this in the test, okay? So remember, what did we talk about on Friday? The difference between serum and plasma. What's the difference? Okay, right. So serum is that liquid portion of the blood, while plasma has those anticoagulants in it, okay? Good. All right, what is the most common sample that is submitted to the lab? From which part of the body? East, right? Okay, good. Remember, I was talking about inappropriate lab testing. You got that John Doe or John Day that comes to the ER and you just order all these rainbow tests. Why don't you want to do that? Okay, false positives, wasteful, causes undue harm to the patient. Okay, very good. All right, this was just a breakdown of the lab. Lab has got a whole bunch of stuff going on, but for you, for this course, what are we going to be focusing mostly on? CLIN lab. And what falls under the clinical laboratory? All that in red. Micro, heme, UA, serology, chemistry, and immunohematology. Okay? So I think that's it. Okay. Common lab panels. So, hematology, what are we looking for? We're looking at blood, and what kind of disease states in the blood are we looking for? Anemias, correct. Your urinalysis panels, what are your most common ones that you're going to see looking for? UTIs, right. And SCE panels, we're not going to get into that till probably module 4. All right, for your chemistries, remember you have your BMP and your CMPs. What's the difference between the BMP and the CMP? Number of tests. Which one has more? There you go. Remember, I said when you do test it, make sure you know the full word and you know the actual abbreviation as well, okay? For BMPs. Oh, and then this slide. There was a question asking how long, remember I was saying if you're down in your aid stations and you have somebody that gets hurt from PT, they just did high exercise, and you don't want to run certain tests on them. So the question was, how long should you wait? So I did my research, and it should be about 24 hours. So as long as your patient hasn't had any high exercise or strenuous exercise for 24 hours, and you think there's something else going on with your patient, then that is that time to go and draw those labs open, okay? Save that. And then there's the errors. So when we talk about hemolysis, what is that? Breakdown of red blood cells. And how will that serum or that plasma look? Kind of reddish, right? Leukemia. Strawberry milkshake, you remember? Yeah, strawberry milkshake, right? And that's excess fat, so it looks really good. Icterus. Jaundice, probably looking at jaundice, got a lot of breakdown of bilirubin, right? Clotted samples, which is platelet clumping. And when we receive clots in the lab, what do? Shut them joints, man. We're not running it. All right? Rouleau. Rouleau is just RBC stacking. You all probably will not see that too much, but just know that could be some type of cell disorder. And then clutoglucans, we will talk a little bit more in module 4. All right, so let's get into lecture 2. Oh, and I just closed it. All right, so for this block, we're going to be talking about bedside tests. And for you all, that is important because you will as a provider, you will have the opportunity to run some tests that are not in the lab. You may have to run it right next to your patient. So we're gonna go in and talk about a little bit of that today. Mind you, these are 50 slides, and you know like 5 or 6 of them is like TLO, ELO, so it's really like 45 slides, okay? Okay, so TLOs, y'all know how to read. ELOs, y'all know how to read that as well. This is your reference. If you like to do extra reading, these are in chapter 7, 29, 65, and 66. All right, so here is your clinical introduction scenario. We post this up here because this is how I'm gonna present questions on your test. So a 27-year-old female presents to a field clinic with fever, dysuria, and lower abdominal pain. The provider suspects a urinary tract infection or a possible pelvic inflammatory disease. Limited lab resources are available. The provider, you all, will perform a urinalysis dipstick and a wet mount microscopy at the bedside. Within minutes, the results guide the decision to initiate empiric antibiotics and determine the need for the treatment or medevac. So today we're going to talk about how you would run a urinalysis or a wet mount if that is something that's accessible in your clinics. All right, so this is just showing that the lab is mandated has the oversight over clinical laboratory testing. All right, so this is the 1988 CLIA, and the Centers for Medicaid and Medicare Services are the ones that, within the Department of Health and Human Services, are the ones that pretty much provide all the mandates, all the policies and procedures. You want to get upset with them. They're the reason why we have to do it the way that we do it. Okay, so this is a very important slide. All right, you might see it a couple times. Just know that the FDA assigns our complexity designations. We have 3 designations. We have high complexity, moderate complexity, and minimal complexity. We're going to go more into that a little later on in our lesson today. All right? So minimal complexity are what's called wave tests. These are those very simple tests. These are ones where you can go to like Walgreens or CVS, and you find those rapid tests on the shelves, like pregnancy tests, rapid COVID, HIV. That's what's considered a minimal complexity or wave test. Then you have moderate complexity, which is non-wave tests, okay? And a lot of moderate complexity tests are available within the lab. And these are those tests that have to be either drawn or collected from that patient, sent to the lab and ran, okay? Moderate complexity. All right, I gotta stay up here. And so within moderate complexity, there is a subcategory that applies to you all as physician assistants, and that is provider performed microscopy, or PPM. And so there's a limited amount of tests that you all can run based on your education and based on your experience that you can run outside of the lab. You can do the results there, and you don't have to worry about dealing with us lab folks, okay? And then you have number 3, which is high complexity, and those are those genetic testing, molecular testing, things like that, that require a little more education, a little more complex, and higher intensity or higher sensitivity testing within the lab. Okay, so very important slide. All right, so moderate to PPM / minimal complexity. So the FDA assigns these as good for home use. The methodology is simple and accurate, and it poses no or minimal harm to whoever is getting tested. So even if it's correct, even if it's tested incorrectly, it won't cause any additional harm to that person. All right, that's considered minimal. This also needs to highlight that in moderate complexity, you all will run what's called point of care test. So you'll probably hear that interchangeably, point of care test / minimal complexity testing. All right, so here you all, PPM, this applies to you all, okay? So a physician, a mid-level practitioner, whether that's an MP, nurse practitioner, a nurse midwife, or a dentist can run these tests. A lot of these tests will you will utilize a microscope to diagnose and treat your patients. So in the specimens that are used here are considered liable, which means they're kind of unstable. So once you collect whatever it is that you're collecting off that patient, you need to go ahead and look at it. A lot of times it's a sample, you're putting it on a microscope and putting it on a slide and then looking at it under the microscope, okay? Controls are not available and there's very limited specimen handling. Okay, another very good slide, you will see a couple of these, all right? So just know that 1 through 9, you all, once you graduate and become physician assistants, are qualified to run these tests at the bedside, okay? So wet mounts, KOH preps, pinworm, burn test, hoist coital, UAs, along with the sedimentation examinations, nasal smears, fecal leukocytes, and qualitative semen analysis. You probably will not see that too often, but it's listed here anyway. And we'll go into these very quickly. All right, so a wet mount. All right, so wet mounts, you're looking for bacteria, fungi, parasites, and different cellular elements. You most commonly will do a wet mount on a female patient if she is exhibiting symptoms like itching or burning in the vaginal canal. All right, you will, as you see up in that top slide there, you'll just take like a swab, you'll swab that vaginal wall. You'll take that specimen, put it on a slide, and you can look at it underneath the microscope. A lot of times in vaginitis, you'll see things like yeast and trichomonas and clue cells. All right? So if I give you a question saying that if you have a female patient comes in, itching, burning, kind of foul odor in the vaginal area, just know that this is the type of test that you're going to perform, which is a wet mount. All right, and these are some findings. This is what it looks like under the microscope. So this first slide over here with the red, that is considered trichomonas. Yeah, that's trichomonas. I gotta look. So all 3 of these are trichomonas, all right? You will not see this again. Just know that trichomonas is, the vaginal discharge can be clear, white, yellowish, or green, and it can have a fishy smell. So that's an example of what a trichomonas looks like. Wet mount findings, you can see a lot of bacteria. Just know that bacteria is normal flora in the vaginal canal, but if there is a whole bunch of bacteria all over the place, then that could indicate something is going on with her, okay? Bacteria vaginitis, you'll see high concentrations of Gardnerella vaginalis, Mycoplasma hominis, and anaerobic bacteria as Prevotella and Mobilonogus species, okay? All right, but this slide is very important because I really like those pictures down there. So you need to know what a clue cell looks like, and you might see a clue cell again. So what is a clue cell? A clue cell are vaginal epithelial cells. These cells look like other cells. The only difference is it's got a whole bunch of bacteria on it, okay? And when you see clue cells in a wet mount sample, then you are looking for bacterial vaginosis, okay? So this is the key indicator for bacterial vaginosis are those clue cells. All right, yeast is also another very common element you will find in BB when doing, getting samples from the vaginal wall. You have some yeast, looks like either budding yeast, look like little buds, or they look like little branches, okay? Associated with yeast or yeast infections, you'll have that white, clumpy, lumpy discharge. And then it says here, budding yeast or pseudohyphae, they look like little branches to me. And yes, you will see this again. All right, so this is just a chart of what we already discussed. If you need to see it, you need to look at it differently. Just focus all the way off to that left side on the microscopy side. So trichomonas, you'll see those little motile trichomonas, they'll be in there dancing and jigging and doing all kind of stuff on the slide. Then you have BB, that clue is the clue cells. And then candidiasis or a yeast infection, you'll see those hyphae or budding yeast. All right, so this is just what we consider normal flora in a wet mount. All right, so you have squamous epithelial cells. These are just normal vaginal cells that you'll see. So if you do see it, don't be alarmed. It's normal and it's asymptomatic. They're flat, angular, they have a very large cytoplasm, and they alone are not pathologic at all. But just because she has disorder, you can still see them in there, but seeing them by themselves doesn't mean that she has anything going on with her. All right, white blood cells. So when you see increased white blood cells, what does that indicate to you all? Some type of infection. So if she has something going on along with, like, so she does have BV, she'll have those flu cells, she'll have the yeast, and you'll possibly see a whole bunch of white blood cells in there as well. Okay. And if this woman is in her cycling, you may see red blood cells. That does not necessarily mean there's anything going on with her. She just could be on a cycle or coming off her cycle. And even a certain amount of red blood cells is still relatively normal to find. But that's what they look like. All right, so KOH prep, potassium hydroxide. So after you do your wet mount with the saline, you want to go back in and get a little bit more sample, put it on your slide, and then put a drop of KOH. So that drop of KOH will help kill everything else. Like if you know there's some fungus in there, but you can't tell because there's a lot going on, you want to drop that KOH, it'll kill all those other elements and will leave all the fungal elements will be left. So a lot of times when you see people with a bunch of infections, it's really hard to determine what's going on. You're like trying to zoom in and zoom out, you can't tell. Drop that KOH and you'll see those budding yeast and the little branches everywhere. You're like, yeah, she got this, she got yeast infection, okay? So make sure you do the KOH prep after you do your saline prep. All right, and so this is just showing you saline prep. You see how you have all those squamous epithelial cells everywhere? And then once you put that drop on there, right, boom, then nothing, right? And then you can see the little branch. That's pretty much what all that's there. Pinworms. So you all are smart. What's the most likely people that have pinworms going on?
Kids.
Little kids, right? Because they be scratching, they be put something around, they be touching the eye, they want to touch you, they want to cough, then they want to smear stuff. Yeah, so pinworms is where you're going to primarily deal with kids, right? So as you can see off to the left, there is a pinworm collection, and pretty much all it is just a pad. It's a sticky pad, and you just take that and you just kind of dab it over around the anal area to collect those samples. Once you get enough, once you feel like you dabbed enough, you just spread that onto the slide, pop it under a microscope, and once you see those little oval-like structures, you know that that child's got some pinworms going on. Okay. Yeah, you will see this again, okay? Fern testing. So what I really want y'all to understand with fern testing can only be done or only be seen in pregnant people, okay? So you can do a wet mount on a woman, you can do a KOH prep on a woman, but fern testing will only be seen on someone who is pregnant, okay? So fern testing is detects any type of amniotic fluid leak. So her water, I shouldn't say that right. If the pregnant person's water broke, and you think that there might be a rupture of the membrane, you can collect some amniotic fluid and it'll look like ferns on the slide, okay? Just note down on the bottom, normal vaginal secretion should not look like this, okay? And that you will see again. So just understand the difference between the wet mouse, the KOH prep, and the fern testing. Post-coital testing. This is not very common. I'm not even sure why it's on here, but it is, and so I have to teach it. So, quality examinations of vaginal or cervical mucus that evaluates infertility. So pretty much what this test is, a person, after they have coitus or they have intercourse, you can collect the mucus 2 to 8 hours afterwards, and from there you can determine if that mucus has a successful chance of fertilization. This is on the test, I'm gonna be straight up with y'all, but you will not see this. This is something you will see in fertility clinics. This is not something you will do in an aid station or in an NTF. But it's on here, so I had to put it out there, all right? All right, urinalysis. Now you all will run UAs. That is something that's very common, okay? And if you've ever done any type of like pool testing or water testing, it's very similar to that, where you just dip that into the liquid, wait a couple of 30 seconds to a minute, look at the pads, and each pad will give you a result of what's going on with that patient's urine. Okay, so this is just a breakdown of the urinalysis, the results, and the reference range. So anytime you get a question on your test about a UA, it's going to look very similar to this. I mean, yeah, it's going to look like this. I'm not going to deviate from it because I don't want to throw anybody off. All right? So no specific gravity, pH, protein, glucose, ketones, blood, leukocyte esterites, nitrite, bilirubin, and urobilinogen, right, are all what's on the dipstick. All right, we're about halfway through though, okay? Urine sediment examinations. All right, so just as you do a UA dip, you could also, if there's something going on that you need to examine, you can also do, this can also work under a microscope. So on that top one, you see those are RBCs. RBCs, if she's a menstrual woman, that could be normal. RBCs in a man, not so much, right? So if you're starting to see RBCs in a male patient or someone that does not have a cycle, then you could probably look to some type of glomerulonephritis, kidney stones, or some type of trauma. If you see white blood cells, a whole bunch of white blood cells in a urine sediment examination, think of pyuria, UTIs, or some type of kidney infection. And then with those squamous epithelial cells in the urinary tract, like I said, that's very normal in vaginal canals, but in those that don't have vaginas, then you would, they could indicate something else is going on, probably some type of contamination. And with further examination, it could indicate some type of tubular damage. But don't worry too much about that. This is FYI. This is another FYI, but I gotta talk about it. Urine cast. They're small cylindrical structures that are found in urine, and they're made of proteins. They vary in size and shape, and they also could be associated with tubular damage, renal inflammation, or infection. So here are some pictures of some casts. And you know which one I really like, y'all? I really like that waxy cast, so you might want to know what that is. So waxy casts, they're smooth with sharp edges, and they have blunt ends, and a lot of times they indicate kidney disease, right? Erythrocyte casts, or those red blood cell casts that could be found. They contain red blood cells, and that can also indicate some type of glomerular damage. Then you have your cellular casts, which is that second one on that second row there. Okay, that could indicate some type of acute tubular injury or infection. Then you have fatty casts, which had just fat droplets. That could be some type of nephrotic syndrome. And then lastly, hemoglobin, which is hemolysis or some type of muscle breakdown. But what is the one that I want y'all to know? There you go. Yes, because y'all will get up out of here. Okay, urine crystals. So just know that there are some crystals that form in the urine. Some can form in acid urine, some form in alkaline urine, and we're going to go into that a little bit more. All right, so anytime you see this is from Major Guzman. Anytime you see that little dollar sign with wings, just know that that's very important, okay? Very important slide. Just memorize it, okay? So acidic, and we'll go into it, but memorize at the same time. So acidic urine, you have uric acids, calcium oxalates. In your alkaline urines, you have calcium carbonate, calcium phosphate, magnesium phosphate, and ammonium biurate, okay? And then I will let you know which ones in particular I want you all to know. All right, so these are some crystals that are found in acidic urine. So when we're thinking of acidic urine, what do you think the pH is going to be when you do that urine dipstick? Good. all right? Uric acidic crystals are commonly found, and that's another word. Anytime you see commonly, you know what, right? Those are associated with gout or high purine metabolism. Then you have calcium oxalate crystals, which are typically found in kidney stones, and that's something you will see a lot as PAs, to see those. Another wonderful slide that I love, I just love it so much, okay? Crystals that are commonly found in alkaline urine. Okay, you have your, let me tell you calcium phosphate, okay? I know, don't tell me, y'all. All right, so calcium carbonate crystals are small and colorless spheres. They look like dumbbells. It doesn't look too much like dumbbells on here. Calcium phosphate, they appear as rosettes or amorphous structures. Then you have magnesium phosphate. Those are commonly found or seen in UTIs. And then you have your ammonium biurates that are typically found in those older urine samples. And pretty much what that means is, as soon as you get that sample from your patient, if you're not running it, please send it to the lab, because the longer that it sits, the more weird stuff that shows up. There's bacteria in there, there's all kind of weird stuff, that all kind of sediments and crystals will form in there, and you don't want to diagnose your patient with something they don't have because you had some urine just sitting out and you didn't want to send it to the lab on time, okay? All right, so here are some more crystals. All right, so cysteine crystals are found in cystinuria. Tyrosine crystals are found in severe liver disease. Leucine crystals are found also in liver disease, and then those last two, sulfonamide and ampicillin, those crystals can be found on those patients that are taking antibiotics. So a lot of times, those patients already have other things going on with them, and if we already know that as laboratorians, then we'll know that it's not something going on with the patient. We know that they're just being treated at the moment. This is another great slide that I love so much as well. So nasal smear, you will do that. I have seen PAs do collect nasal smears, and a lot of times that's for those who have, you have those that have a lot of allergic reactions. You will see a lot of eosinophils that show up in the nasal. Now granted, if you all were to collect this at the bedside and look at it under a microscope, it will not look like this. You would bring it to us, we would stain it, and then we would help you all with your diagnosis there. So anytime, as you can see highlighted, anytime you see greater than 3 eosinophils in a slide, just know that you're looking for allergic rhinitis or infections. Okay, indicative of allergic rhinitis. All right. Fecal leukocytes. We're going to get a little bit more into this, into micro, so I'm not going to harp too much on it. Just know that fecal leukocytes is something that you could possibly collect at the bedside. This is also in response to infections, and that it is a good indicator for salmonella or shigella infections going on. So a lot of times, if there's something going on, if you see this under a microscope, they're probably having they're throwing up, they got profuse diarrhea. And a lot of times they're already being treated as an inpatient. You usually don't see these on outpatient people. And then qualitative semen analysis. Yeah, you all are probably not, unless you work in the medical centers, but you all in your, when you first get introduced, you probably will not be doing this. You will refer this up higher. But for the sake of this program today, your qualitative semen analysis is pretty much saying you're identifying that there's sperm present or there isn't sperm present. A lot of times you'll see this after men, well, I can't say men, people who have penises, right? When they go and get a post-vasectomy, they'll usually come back in to make sure that, that those things are gone, right? They don't want that sperm anymore. So pretty much you're just there to tell them, yes, you have sperm, or no, you don't have sperm there. And when collecting semen analysis, the guideline is to ensure that there are abstinence for 2 to 5 days prior to. They have to ejaculate entirely into that cup, and it must be kept at room temperature, and please get that tested within 30 minutes because those little sperms will die off. Right? And that's all I say. And you really don't, and I've seen this happen, where people have delivered samples late, and we're like, yeah, they're not moving anymore. Can you submit some more? So that does happen. So please get it to the lab, or if you're running it, please run it, because like I said, we will reject those specimens, and you don't want to do that again. You don't want to see your patients again. So even though this is a little money slide with the wing, it's good to know. I decided that I was not going to do any further testing with you all on this, but it is a good slide for you all to know. Okay. And then this is just showing an example of automated semen analysis. You may have a little piece of equipment in your clinic, and these are just some of the tests that it runs. So, percentage, the concentration, functions, velocity, stuff like that. All right, so do you remember what complexity that point of care testing falls under? Minimal, right. And provider performed microscopy falls under which complexity? Moderate, and that applies to you all, okay? High complexity testing is what? The specialist, yeah, that's me, correct. All right, so this is just showing some advantages and limitations of point of care. The good thing is that it's a short amount of time because you can take care of it in your clinics. It's convenient, and some of it is exempt from CLIA exemptions. It does require some additional training on your part, and sometimes it can be, the cost can be a little bit more sometimes, all right? And accountability sometimes can be a challenge. So here's just some examples of the core lab of point of care testing. A lot of this you'll see on the wards, like the hemicubes. Like for anyone that's ever given blood, you know how they prick your finger in the beginning? That's what they're doing. They're looking at your hemoglobin. If you've ever seen patients that are that are on warfarin or Coumadin, they will also get their PT test done before they go to their appointments. And then on the bottom, you have the glucometers. So for those that have, get their glucose test done. A lot of times they do that before they take their medications. And then in those point of care tests, you can test glucose, urine, creatinine, cardiac markers, and pregnancy tests. And so pregnancy tests can be done off of the blood or it can be done off of urine. So this is just a breakdown. It's just an iStat. This is used heavily at the bedside, and a lot of times, and I don't know, I haven't deployed in a while, but on deployment we use this a lot as well. Our iStats, it was real convenient, and it was very, it helped our physicians out a lot. And then it's just another example of a chemistry machine. A lot of times you'll see this in smaller clinics as well. We call it Piccolo, and these are all the different panels. But we're gonna go more into panels into block 2. This is just an introduction of panels, so be prepared because I know you all don't like panels, but we have to teach it. All right, and then here's some more examples under microbiology. So strep throat is very common. You all will do that a lot. You all will do influenza, RSV for the babies, BV, trichomonas, and one that's not on here that should be on here is the COVID-19. That falls under the micro point of care test as well, that rapid COVID-19 test. Okay, here is just showing rapid antigen assays, okay? This is just showing that what a positive result looks like, what a negative, and what an invalid. And so by looking at the pictures, how do you know, or why do you know that it's an invalid test? What is missing? The control. So you always have, the control always has to come up positive, whether that patient is negative or positive, okay? All right. So this is rapid HIV, same concept. And then fecal occult blood, you all will also have the opportunity to test for fecal occult blood. And so pretty much you have your patients bring you a sample of their stool, and you'll just take a little smear, put it on the back of that card, and then you put 3 drops down. So the 2 drops on the smear is one on the control, and if it shows up blue like you see here, then you know that your patient has some blood going on in their stool. Okay, so it's a very quick test that you can do right in your clinics. And if they have something going on, of course, refer them up, but at least you have something there right in the bedside. And what? ELOs and what? Questions. No, you're like, nah, I got no questions. Anybody have questions? That's it. I will see you all, what is our next day? Our next day is the 23rd, is that correct? OC Arnold, 23rd is our next day, okay?